So hi everyone, welcome to the section on immunizations. So over the next 45 minutes or so, we're going to talk about three main things. One is the routine immunization schedules. So the second is catch-up schedules, and the third is special immunization cases that the board likes to ask about or talk about. So before you get started, and I promise I'm not going to read through this slide, it's really important to look up the immunization recommendations. This is a really great slide to print out and keep by you and review. The more important one probably is the catch-up vaccine, and I split it into two different slides. So there's a catch-up vaccine for 0 to 6 months, and then 0 to 6 years, and then 7 to 18 years. And these are the tricky cases that you may get asked about. Again, they're really helpful to review right before. One thing that's newer is the special medical indications, and this is really about those special cases that will be at the end. Again, this is one that I would probably print off and review close to the boards just to remember what these special cases are. So let's start with some live vaccines. So this is one that often will pop up, and so there are multiple live vaccines to remember: MMR, varicella, rota. Remember the nasal flu, which we now give again, oral polio, yellow fever, and then typhoid, but only the oral typhoid. So the next section, we're going to go through some immunization updates or really important information. So the first is hepatitis B. So remember, in a hepatitis B surface antigen negative mom, you're going to give the first dose to a stable infant that's greater than 2 kilograms or 2,000 grams. Infants that are less than 2,000 grams can receive that vaccine either at discharge or at 1 month of age. And that's the majority of our children, and so that's the one that we're all familiar with. For the hepatitis A surface antigen positive mother, the hepatitis B vaccine and the HBIG need to be given within 12 hours regardless of that baby's weight. And then the infant needs to have their series completed in a quick manner, so by that 6 months, and then have testing done at 9 to 12 months, or if you were not able to complete that series within the 6 months, then it would be 1 to 2 months after the series is complete. So this one I start as important because this is a tricky one. So for the hepatitis antigen unknown mom, so the mom who potentially doesn't have prenatal care or didn't get labs done or a whole series of reasons, don't know her hepatitis status. So the Hep B vaccine within 12 hours regardless of birth weight. The HBIG is going to depend on how old the child is. So HBIG within 12 hours for the infant less than 2,000 grams. For the infant that's greater than 2,000 grams, you have time to determine the mother's hepatitis status. Do that quickly, and then give the HBIG within 7 days to the infant that's greater than 2,000 grams, only if that mother is positive. So let's switch for a minute to MMR. So there's been a lot of outbreaks of different vaccine preventable diseases, and so this is a newer recommendation with some of these new outbreaks. So in a mumps outbreak, children greater than 12 months who have already received 2 doses and are at increased risk will get that 3rd dose. So that start as new. Let's switch a little bit for children going on international travel, and international travel does become questions around vaccines. So you're 6 to 11 month old, you can give the MMR vaccine prior to departure, but when that child returns, they need to have 2 additional doses that are between 1 year and older. So that 1 dose gives them some protection during travel, but it does not count towards full vaccine. So switching to the HPV vaccine, so now we all use the 9-valent HPV vaccine. I don't think they would ask you. The first 4 serotypes were 6, 11, 16, and 18, and then the high-risk cancer strains were added a number of years ago. This is a highly effective vaccine, yet few teens receive the full 3-dose series, and less boys than girls, but in both groups, less than 50% receive the full 2 or 3-dose series. So this is a really important point for counseling. As far as the vaccine schedule, you can see what it is here. A couple of things to point out. So in children between 9 and 14 years that are not immune compromised, they can get only 2 doses. That tends to be a selling point because they get 2 shots and not 3. If they wait till they're after over 15 years of age, they do need all 3 doses. And any immune compromised patient needs 3 doses. In general, we start the HPV vaccine at that 11 to 12-year-old visit. It has been demonstrated to have more acceptability for parents when it's given at that visit. The one thing to remember is if a child has been sexually abused, they should start the HPV vaccine at 9 years of age. So that's the one real indication for starting it earlier. So switching a little bit to meningococcal vaccine. So we do our first vaccine at that 11 to 12-year-old visit, and then you can see there's an increase in disease rate, which is where the reasoning behind that booster dose, more at that 16 to 18-year-old age. So our common MCV4, which there's 2 different brands, Menactra and Menveo. The serotypes are ACW135 and Y. The reason why that's important is because different types of meningitis are in different parts of the world. So B, C, and Y cause most of the infections here in the US, and you can see B is not covered in either Menactra or Menveo or the MCV4. But children traveling to endemic areas need the vaccine for both the A and the Y. The real only contraindication, hard contraindication, is Guillain-Barré. And as we showed in that graph to start, the antibody levels wane within 5 years of that first dose, and that's why we go ahead and do that booster dose. Again, here the routine schedule, if you start that first dose at that 11 to 12-year-old visit, the booster is at 16. If the family either misses that visit or doesn't want the vaccine and they get it then at 13 to 15, they get the booster potentially 16 to 18. But if that first dose is given right when they're older than 16, they don't need a second dose. And that clearly, that is different for immunocompromised children. So for children with certain diseases, so asplenia for any reason, including sickle cell, HIV, complement, they do need to receive the meningococcal vaccines earlier. There's different indications, and I have them listed here. Some Menactra goes down to 9 months of age that you can give it. Menveo is the other quadrivalent meningococcal vaccine, and that one can be given as young as 8 weeks of age and is given similar to the primary series of other vaccines that we give. And again, children who are traveling or live in areas where meningococcal vaccine is epidemic, we would go ahead and give that earlier. And again, you can see the 2 brands that are available and the different ages in which they would start. So switching to the meningitis B vaccine or meningococcal B vaccine, I highlighted this as important. I guess it should be new. It's not really a new vaccine, but the uptake is newer here in the US. So remember, meningitis B causes about 30% of meningitis cases here in the US. Individuals who are older than 10 have increased, or those several types of individuals have increased risk, and you can see the asplenia in areas where there's more outbreak. And those children should receive the Men B vaccine. The other indication is to think about it for healthy children age 16 to 23 who are not at increased risk. So we think about it for children who are going to the military, going to college, that 17, 18-year-old visit. It's not approved on all or many insurances, and so it's not widely given, but it is a recommendation to consider and not a hard recommendation to give. So the meningitis B vaccine is approved for people between ages 10 and 25. There are also 2 different brand names, and that won't be important for the boards. It's more information for you if you're interested, and they are licensed as either 2 or 3 dose vaccines. So looking at flu, and I wanted to bring back flu. You all know a lot about flu. We talk a lot about flu shot in primary care as well as hospital medicine, ED, all of our rotations. So flu shot is indicated for children, all children greater than 6 months. Children between 6 months and 8 years need the 2 doses. Those that get their first flu vaccine after 9 years only need 1. The big contraindication is a severe life-threatening reaction to a prior vaccine or vaccine component. Of note, in the last few years, egg allergy is not a contraindication, and the majority of children with egg allergy can receive and should receive flu shot. So back this year is the live attenuated nasal flu vaccine. Back about 1 to 2 years ago, it was stopped because it was thought to be ineffective, and then this year became an option again. It is only an option for children over 2 years of age. Contraindications is, again, that severe allergic reaction to a vaccine component. What comes up more for us is you should not give it for children with a history of wheezing in the last 12 months. And remember, it is a live vaccine, and so again, immunocompromised children. So we're going to switch a little bit to some special scenarios. So thinking about allergies, so individuals with egg allergy, so influenza, if it was severe anaphylaxis and they ended up in the trauma bay and almost died, probably have allergy, see them, but again, routine egg allergy influenza is okay. So really the big thing now for egg allergy is yellow fever. Individuals with gelatin allergy, I don't know who would know they had a gelatin allergy. I've never met anyone who said that on their allergies, but MMR and varicella. And individuals with neomycin allergy, again, I don't know, I've never identified that one, but for the boards, MMR, IPV, and varicella. So IVIG is a big special consideration. It's very confusing, and IVIG and blood products have a lot of different requirements. So so IVIG administration, you're really thinking about live vaccines and when to give them. So the duration after the IVIG was given to when you can do the live vaccine varies. It really varies by the dose. You can see 8 to 11 months. So the more they got, the longer you should wait. And that, again, that's something you would definitely look up in the Red Book and practice. I don't think they would ask specifically, but just know that in theory. The one that they could ask, so if you had a child who received their MMR or varicella and then within 14 days had something else that they needed IVIG, then those vaccines would have to be repeated. They would not count. So RSV prophylaxis is one that has no weight. A child who is receiving RSV prophylaxis should get all immunizations, including live immunizations, at the appropriately scheduled time per CDC recommendations. And then again, blood products, different blood products have different time weight with vaccines. So steroids, again, steroid therapy, really what we're worried about is live vaccines. So the first thing is all of our children with eczema and allergies that are on topical and inhaled steroids, vaccines are A-OK. Please give them and make sure they get the flu shot. For children on low or moderate dose steroids, which is defined by less than 2 mg per kg or 20 milligrams per day, they can receive those live vaccines during their steroid course. So if you're seeing a child on low dose steroids as a hospital follow-up, as the scenario, and they need their MMR and varicella, you can go ahead and give it at that hospital follow-up visit. Those that are on high dose steroids, if it's less than 14 days, the recommendation would be to wait to give those live vaccines until after they stop treatment. Some would recommend waiting 2 weeks. And then longer high dose steroids, and again, that 2 weeks is that magic number, they should receive the live vaccines once their therapy is discontinued. So HIV is an important one, so HIV and immunizations, and again, HIV is not a topic we see, or we don't see a lot of children with HIV here, so this would be a topic I would review. So guidelines for vaccines with children, so they should get all of their routine immunizations. They definitely should get their flu shot. And then what changed earlier, so we used to not give rotavirus, since it is a live vaccine, to children with HIV, but that's been changed. And if they were HIV exposed, you should do it, but do it with precaution. And then you can see all of those other vaccines that are appropriate. So HIV and live vaccines, so we're talking about your MMR and varicella. So they should be given to children with CD4 counts of greater than 15% or greater than 200. So basically, if you're not severely compromised, you should get your live vaccines. And then moderate to severe, so MMR and varicella is contraindicated in children with that moderate or severe immunocompromise. And then, although you can give your MMR and varicella separately, there is a recommendation not to do ProQuad or the MMRV combined vaccine. So the other topic which might come up is chemotherapy. So here's a case example for you. So you're seeing a 13-month-old healthy child, previously immunized. It's January and they're here for their well check. Dad tells you that mom was just diagnosed with breast cancer and she's receiving chemotherapy. So what vaccines can this child receive and not receive? So think about it for a second. So what can they receive? You're right, all of the normal ones. MMR, varicella, your DTaP if it's been 6 months since their last DTaP. The IPV if they need that booster and they haven't received it at their 6-month visit. The Hib, the pneumococcal or Prevnar, definitely give them their flu and their Hep A. So what can they not receive? This one I'll give you a second to think about. This is tricky. Once again, you're right. So nothing that we would give in the office. So they cannot receive oral polio or smallpox, which is nothing that at least we do at PPC. So, so you'd be fine giving them all their routine 1-year-old shots. Okay, so here's another case. So this is a 2-month-old. They're healthy and they received their normal 2-month-old shot. So their DTaP, their second hepatitis, their Hib, their PCV13, their IPV, and their Rota. And then later, this little baby ends up in the ED with a fever of 104, limp, unresponsive, and looks pretty sick. So what does this child have besides something really scary? Great, the hypotonic hyporesponsive episode, or HHE. This is self-resolving and does not lead to permanent damage. And what most likely caused this? The DTaP vaccine, and that would give it a relative contraindication. So at that 4-month-old, you would give all the routine vaccines, but instead of the DTaP, what would you order? You could order the DT separately and not use that pertussis component. So contraindications to DTaP. So there's really only one absolute contraindication. So encephalopathy within 7 days of DTaP, and that's really that progressive neurologic disorder. Precautions: if a child looks sick and has a very high fever or seizures within 3 days of a prior vaccine or Guillain-Barré, but in general, very few contraindications. So we are going to switch to some of the tricky details, and this is honestly one of Dr. de Blasio's and my favorite topics of how do we catch kids up and what are these little tricky details. So DTaP is a fun one. You guys know the routine: 2, 4, 6, and 12 to 18 months, booster at 4 to 6. The DTaP is approved up to age 7. And here's the detail. So duration between the 3rd and 4th dose. So that has to be 6 months. And that's why many of our 12-month-olds may not get their 4th DTaP, because if their 3rd one was given after 6 months, we need to wait 6 months. And here's the special case. So you should ideally have 5 doses of DTaP: 2, 4, 6, 12 to 18, and 4 to 6 years. But if you get your 4th dose after your 4th birthday, you do not need that 5th dose. So as you know, Tdap reduces the risk of pertussis quite effectively. There are two different brand names for them. We give Tdap at either 10 or 11 based on the brand and what age it was approved to. Now DTaP, on the other hand, is only approved through age 7. So what do you do for a child who's 7 to 10 who's not received all of their DTaP or their pertussis vaccines? So there is again, this is a special case. So a 7 to 10-year-old who has not received all of the tetanus and pertussis containing vaccine can get a DTaP between that 7 to 10 years. And then if they need a lot of catch-up vaccines where they're going to need more tetanus-containing vaccines, they would get the remainder of that series as capital T, little d. Your Tdap can be administered regardless of the interval since the last tetanus. And then again, something that's a little bit newer is that Tdap to all pregnant adolescents at each pregnancy, regardless of how long it's been. So let's switch to IPV. Again, the normal schedule, 2, 4, 6 months is how we normally do it. That third dose can be given anywhere between 6 and 18 months, and then a booster at 4 to 6. So you receive 4 doses of IPV. The special case is very similar to the DTaP. If you get that third dose after your 4th birthday, and it's at least 6 months after the second dose, you do not need that 4th dose. So very, very similar. It's just this is the third dose instead of the 4th dose as it was with DTaP. Okay, so a little bit on Prevnar. So PCV13, it's approved for children between 6 weeks and 71 months. You can see the serotypes initially when pneumococcal vaccine was released as a PCV7 back in like 2000, and then a number of years ago it was switched to PCV13, and they added additional serotypes which were emerging causes of infection. The typical dosing schedule, you know, at that 2, 4, 6, and 12-month visit, but think about PCV13 for unimmunized children between ages 6 and 18 who have a specific risk for invasive pneumococcal disease. So again, think about your spleen, HIV, renal failure, malignancies, transplant, CSF leak. I think we would notice if someone walked in with a CSF leak, and think about more than just their PCV. But we have more and more children with cochlear implants, and so again, PCV normally ends. We don't do it after age 6. But if you have an unimmunized child over age 6 who has a cochlear implant, please remember that they need 1 dose. So just one side on the pneumococcal polysaccharide or PPSV23 vaccine. This is one we don't talk about a lot. We don't actually even have in PPC, but this is administered for children at age 2, as long as it's greater than 8 weeks after they've completed their PCV13 or their Prevnar vaccines in very specific cases. So cyanotic heart disease, chronic lung disease, which they include asthma on chronic high-dose steroids, diabetes, again, the cochlear implants and the CSF leaks, immunocompromise, which makes sense. In there includes patients who have had a transplant, and then any sort of functional asplenia or anatomic asplenia. For children who receive this vaccine, they get revaccinated after 5 years. So the Hib vaccine, again, the recommended series, you all know from your continuity clinic. A couple of things to remember: it needs to be 8 weeks between the last dose and the booster dose. And if an incomplete series, you need a booster dose after 15 months. So oftentimes, Hib ends by the time children are 5 years of age, but for children that are greater than 5 that have not received the Hib series, they receive 1 dose if, again, they have functional or anatomic asplenia or HIV infection. And then if a child who had been previously vaccinated receives a stem cell transplant, they would again repeat the Hib immunization. So hepatitis B, just a couple of little details. The details really are related to the spacing. So the first to second dose is 4 weeks, the second to third dose is 8 weeks, and you really only need 16 weeks between that first and the third dose, but that child also has to be over 6 months of age. So Rotavirus vaccine, there's 2 different brands again, Rotarix and Rotatec. One is 2 doses, one is 3 doses. In our clinics, we tend to have Rotarix, so the one thing to remember, if they did receive 1 Rotatec, which is the 3-dose regimen, they would need to have 3 doses regardless of what those other 2 vaccine brands were. The tricky part, so once you are 14 weeks and 6 days of age, you can no longer start the rotavirus vaccine. So you need to have that rotavirus vaccine started before you're 14 weeks and 6 days. And then it needs to be completed by 8 months. So a child who had 1 and comes in at 9 months for their next visit can no longer get that rotavirus vaccine. Contraindications, again, are really that severe reaction to a prior dose. And then think about it for severe gastroenteritis, severe febrile illnesses, immune compromise, really HIV, and then chronic GI disease, and if they currently or have a history of intussusception. So this is a really common one. This is the rash, and I will tell you that this child was immunized about 9 days ago and now has this rash. What do you think? Which vaccine caused this? Great, the MMR vaccine. What is really common with this vaccine is the fever, and it usually is 7 to 10 days after the vaccine. So if they ask you this one and they tell you the vaccine was 7 to 10 days before, you know it is MMR. In the office, it's really tricky. 7 days ago feels like a lifetime, and parents forget that that child had received a vaccine a week ago. So MMR vaccine, again, the routine is 1 year and 4 to 6, but it is approved for children greater than 6 months of age, really for children who are traveling to endemic areas. Varicella vaccine is also at 12 months and then 4 to 6 years, and then the post-exposure prophylaxis would be if you're a susceptible if you're an immunocompetent child, you should receive the vaccine within 72 hours of exposure. Very few people actually get the immunoprophylaxis or the varicella IVIG, so it's really immunocompromised children within 96 hours. And then there's very strict rules around newborns whose mother have a varicella infection. The mother has to have the varicella infection within 5 days before or 2 days after delivery in order for the child to get the passive immunoprophylaxis. All right, so some quick, easy questions. So what's the minimal interval between 2 live vaccines? 1 month, great. So what's the minimal interval between the first and second dose of MMR? Remember, this is a live vaccine. No trick here, 1 month. So the next question, what's the minimum interval between the first and second dose of varicella? Again, another live vaccine. Here's the tricky detail. It is 3 months. Except, here's the next tricky detail. If that person is greater than 13 years old, it's actually only 1 month or 4 weeks. And so again, remember that children who have not been vaccinated, who are teenagers, are at higher likelihood of adverse reactions from varicella once they're teenagers. So it makes sense that you could give that booster dose sooner rather than having to wait that 3 months. For non-live vaccines, there's actually no minimum interval. So if a parent wants to come every other day and split up every shot, that's okay. I don't know why they would, but they could. But the live vaccines do have minimum times between them. So rabies. So which are the animals most likely to carry the disease? So there you go, bats. Bats are the big one. Skunks, raccoons, coyotes, foxes, etc. So the recommended shot series, so it's the 4-shot series on day 0 with immune globulin, and then 3, 7, and 14. So here's the thing to remember. If immune compromised, it's actually a 5-shot series with an additional dose at 28 days. And then remember prophylaxis for vaccine for people who are traveling. All right, well, thank you for listening about immunizations. You guys got this. You've learned this in continuity clinic, and good luck on the boards. Thanks. Bye.